All right, let's jump right into a really high-stakes surgical scenario. In this explainer, we're going to simulate a surgical viva, that critical oral exam, and we'll break down the entire thought process for a classic case, the thyroid nodule. We're going to cover the whole thing, from the moment the patient walks in all the way to the long-term plan. Okay, here's how we're going to tackle this. We'll walk through it just like in a real consultant exam. We'll start with the clinical scenario, then move on to history and examination. After that, we'll get into investigations and diagnoses, then talk about management and, importantly, how to handle a crisis. And finally, we'll wrap up with the pathology and follow-up. All right, let's get started. The examiner kicks things off with the clinical case. This is really the candidate's first chance to make a great impression, to show they have a clear, structured way of thinking. So here it is, the classic opener. Now, a good answer here isn't about rattling off a list of diseases. Nope. It's about demonstrating a safe, organized, and thorough approach right from the get-go. How you answer this one question, well, it tells the examiner a whole lot about how you think. Okay, next up, we're gathering clues. This is where a systematic approach to the history and the physical exam becomes absolutely crucial. You're building your case, right? Forming that initial list of possibilities. So the examiner pushes a little. They're not just looking for a checklist. They want to see if you can methodically piece together the patient's story, thinking about everything from the totally harmless to the really serious.
A really strong answer would cover these key points. First, the lump itself. Has it grown fast? Is it painful? See, rapid growth is a huge red flag. Next, you've got pressure symptoms. Hoarseness is a big one. It suggests the nerve to the voice box might be involved. Difficulty swallowing or breathing are also serious. Then you have to ask about thyroid function, any weird weight changes, heat intolerance, heart palpitations. And then, critically, you have to screen for malignancy risk factors. We're talking about things like radiation to the neck as a child or a family history of thyroid cancer. And finally, you have to ask about symptoms that might suggest the cancer has already spread, like bone pain or unexplained weight loss.
And then the examiner throws in a giant red flag, a positive family history. This changes things. It immediately makes you think about hereditary syndromes, and you can bet this detail is going to be super important when we talk about management later on. All right, so we've got the history. Now it's time for the hands-on part. The examiner wants to see your clinical skills in action, how methodical and thorough you are. Okay, this is the textbook way to do it. You start with a general look. Are there any obvious signs like tremors or bulging eyes? Then you zero in on the neck. You ask the patient to swallow, and if that lump moves up, that's a classic sign it's part of the thyroid. And here's a key tip. Always palpate from behind. It helps the patient relax their muscles so you get a much better feel for the lump's size, its texture, and if the trachea has been pushed aside. From there, you meticulously check all the lymph nodes in the neck. And you don't stop there. You'll percuss the chest to see if the thyroid has grown downwards, and you'll listen for a brute, that's a whooshing sound, before finishing up with a check for any signs the disease might have spread. Okay, we've gathered all our clues from the patient and the exam. Now we bring in the technology. Let's see how investigations help us zero in on the right diagnosis. This is all about good clinical judgment. You don't just order every test in the book. You have to pick the ones that give you the most bang for your buck, the ones that will actually answer your main questions. What's the gland's function, and what exactly is this lump? And there you have it. The candidate nails it by ordering the two most important initial tests. The thyroid function test, or TFT, tells us the nodule isn't pumping out extra hormones. That's good to know. And the ultrasound gives us the anatomy, the size, and the fact that it's a solid mass, which helps us gauge the risk. So the picture is getting clearer. Normal function, solid nodule. Okay, so here's the bottom line. We have a solid lump, but we still don't know if it's benign or malignant. So what's the one definitive test you need to find out? The examiner is waiting for that one key answer.
The answer, an ultrasound-guided fine needle aspiration, or FNA. This really is the gold standard. You use the ultrasound to guide a tiny needle right into the nodule, pull out some cells, and send them to the lab. It's minimally invasive and incredibly accurate for diagnosing thyroid cancer.
And here we go. This is a classic twist in these exams. The result comes back, and it's indeterminate. Bethesda 3. What this means is the cells look follicular, but the pathologist can't tell if they're benign or cancerous just by looking at them on a slide. The only way to know for sure is to take the whole nodule out and see if the cells have broken through the capsule. So yeah, this result is a huge clinical headache. So now the pressure is really on. You have an uncertain diagnosis, you have to come up with a management plan that's both safe and easy to defend, and you just know the examiner is about to throw a wrench in the works to see how you handle a crisis. This is all about clinical judgment. The examiner wants to see if you can put all the pieces together. It's not just about that fuzzy lab result anymore. It's about combining that uncertainty with the patient's major risk factor, that strong family history.
And this is a great answer. It's both safe and decisive. The candidate smartly weighs the fuzzy FNA result against that high-risk family history and says, we need to operate, specifically recommending a total thyroidectomy. That is a very solid, defensible plan. And notice, they also mention talking to the patient, getting proper consent, and doing crucial pre-op checks like looking at the vocal cords. That shows great patient-centered care.
And there it is, the crisis. This is the ultimate test. Can you think clearly when everything goes wrong in the operating room? Acing this question is all about one thing, and one thing only: patient safety. That is the perfect answer. You see the injury, and your first thought is, do no further harm. If you keep going and try to remove the other side, you risk injuring the other nerve, which could be catastrophic for the patient. We're talking a potential permanent tracheostomy. So the right move, the safe move, is to stop, finish up on the side you're on, and wait for the final pathology report to decide what to do next. Okay, crisis averted, but we're not done yet. The last piece of the puzzle is that final pathology report. What it says will determine everything about this patient's long-term care. And there it is. The pathology confirms it. It was cancer. This is a huge moment because it proves that the candidate's initial call to operate, based on that high-risk profile, was absolutely the right one. And now it tells us exactly what we need to do next. So here's the complete long-term plan, and it's a team effort. First, you counsel the patient for a completion thyroidectomy to remove the rest of the gland. And the consent for that surgery has to be rock solid, explaining the higher risks. Next, they'll see an endocrinologist for radioactive iodine treatment. The cool thing is, thyroid cells love iodine, so this radioactive dose seeks out and destroys any stray cancer cells. And then it's all about lifelong monitoring. We'll track a blood marker called thyroglobulin, it should be 0 after all this, and give them thyroid hormone. That's not just to replace what the gland used to do, but also to suppress another hormone called TSH, which can actually encourage cancer cells to grow. And let's wrap up with one last question, just like a tough examiner would. What if that first FNA had screamed cancer from the get-go? How would that have changed your initial plan? Would you have gone straight to a total thyroidectomy and maybe even a lymph node dissection right away? You see, thinking through these what-if scenarios, that's how you really master this stuff.